Well, I guess in the interest of time, I think we'll get going here. So, good afternoon, everybody, and welcome to the monthly Discovery to Commercialization series. Today's session will be focused on moving digital innovations forward, and we got a great list of speakers today. So, for those of you who don't know me, I'm David Granville, Executive Director of ECHRI and a professor at the University of British Columbia. At this point, I'd just like to acknowledge that we are conducting our business today from the homes and offices on the shared traditional homelands of the Musqueam, Squamish, and Tsleil-Waututh peoples. So, for those of you who don't know, we had a strategic plan in the Faculty of Medicine a couple years ago, and one of the areas that was identified as an area that we need to improve was actually trying to bring people together with respect to understanding what the academics are doing, what the clinicians are doing, as well as what the local industry is doing. So the purpose of this Discovery to Commercialization series is not only to improve awareness for trainees about what's going on, but also to make people more familiar and bring people together from both the scientific, clinical side, as well as from the industrial private sector side, and to form new relationships. So we have a great list of speakers today. We're going to start out with James from Thrive Health, followed by Mariam, and then go into questions and answers after the first two talks, and then go into our second two talks by Sidhu and Richard Lester, as well as, and then wrapping it up with Kendall Ho, who's currently double booked and presenting elsewhere and will be joining us towards the end. Just a few housekeeping notes. This event is being recorded, and as per usual on Zoom meetings, if you have any questions, please use the chat box and the moderator will lead the answers and questions. So at this point, it gives me a great pleasure to introduce our moderator for today, Ian Begg, who is the Managing Director at the Innovation Partnerships at the University of British Columbia. So at this point, I will pass the mic over to Ian.
Thanks very much, David. Welcome, everybody, and thanks for inviting me to do this. Kara, can we pop up the first slide, please? I'm going to talk just a little bit around innovation at UBC at a very high level. I'm, as I said, the Managing Director of Innovation Partnerships, which is an attempt to connect both researchers within and without the university and external partners, whether they be non-profits, government organizations, or industry. Next slide, please. Just in case you didn't know, UBC is kind of quite a big organization, roughly about $619 million worth of annual research funding, out of some almost 9,000 research projects ongoing. We typically have roughly about 1,300 sponsored research projects with industry every year. And as a result, we've been able, over a period, to be able to generate roughly $11.5 billion worth of revenue as a result of these discoveries. And next slide, please. The thing I wanted to emphasize here really was that because UBC is so big, you really do need kind of a front door. And David is fabulous in medicine and Vancouver Coastal Health, but there are other ways to talk to some of the other researchers. And in our group, we typically look at trying to transform research and scholarship into some form of impact. And we look at this through a number of different, what you might call, pathways. The commercial pathway is probably the one that's most familiar, which is typically around licensing and other forms of royalty generation. We have a very active entrepreneurial community through entrepreneurship at UBC, which has been very successful in spinning out a great variety of both life science, medical, and other science ventures. When it comes to the non-commercial aspect, whether it be policy, best practices, SOPs, then we have a group which handles that. And my group handles the partnerships which enable both companies to be able to set up working relationships and research with the university, but also helps to support some of the other areas. One of the things we try to do is connect people so you can understand research, innovation, and the experts. We can provide a talent. We've been very good at getting students engaged as a learning experience, but also to help companies. We have infrastructure at the university. We have a supercluster project relating to the COVID virus that is using substantial pieces of infrastructure. And we can also provide funding opportunities if you want to do research. You don't have to pay for it all yourself. I mentioned the digital supercluster there, and we're also the lead point for that. The supercluster is a co-investment model and is currently looking to fund up to $30 million worth of projects. And if you want to talk about that with me, I'm very happy to do so. With that, I'm going to, thank you. And the last part is seeding innovation. One of the things that we try very hard at the university is to try and convert what is just research into something that can be innovated. It's not always an easy path because there are many conflicting interests, and we guide people through that. So, Cara, I'm going to introduce James now. So let me introduce Dr. James Halliwell. He is a cardiothoracic anesthesiologist, an entrepreneur. He successfully built and then sold a medical device company, taking the product from concept to sale in the span of just a few years. He is currently the founder and CEO of Euphraxia Pharmaceuticals, which has developed a novel drug delivery technology with assets in multiple clinical areas. Additionally, James is the co-founder and chief medical officer of Thrive Health. He brings an invaluable perspective to product development and long-term vision to improve the delivery of healthcare in Canada. And it's my pleasure to introduce Dr. James Halliwell. James?
Thank you very much, Ian, for the kind and warm introduction. It's actually great to be talking to a lot of people. I miss doing it in front of everybody, but it's wonderful to be in front of you digitally, and thank you for taking the time. I'm going to share my screen here, so you're going to be able to actually see, if I'm able to take over the screen sharing. There we are. Fantastic. As long as people can see that there. So let me tell you a little bit about the story about Thrive Health. So Thrive Health really comes from myself, who you heard a little bit about, and my brother, who is actually the CEO, one of the other co-founders, who is a successful tech entrepreneur, and his previous business partner, Greg Kerfoot, who also has been a very successful tech entrepreneur. And a few years ago, the three of us started talking about the things that we felt that we could do to really actually make the health, particularly British Columbians, but also Canadians, much better, and to help them feel much more connected to their health journey. And so that's really what we've tried to do. And so our mission in starting this was to improve the delivery of healthcare, focusing on patients. And one of the interesting things is that obviously there's a lot of data in healthcare, and you see that every day, and it's often quite disjointed. One of the things that is at the absolute core of what Thrive does is that whenever we have an interaction that occurs between a physician, a system, and a patient, the patient actually always owns the data that remains in our system. So they can access it anytime, they can keep it, they can store it, they can look at it, and they can also ask us to delete it, what resides on our system. And so they have a real sense of control and feel that there's a lot of advocacy for them. We also help them try and navigate through the system while also making sort of the system function more efficiently, as well as giving clinicians a lot of tools to be able to help them prioritize their time to delivering the excellent care that they do and less on the administrative burden. So we'll talk a little bit about the journey and then how COVID ended up playing into this. So first, we have lots of partners across Canada, and you'll hear a little bit about some of them and other projects that we won't have the time to go into today, but we're always very pleased to really work with a lot of partners that have been very lucky with just the innovation that has been seen in British Columbia and across Canada, and just how keen people have been from universities, from health authorities, from the Ministry of Health, and just how supportive they have been to really try and drive innovation and put a lot of control in patients' hands. And that's been really good. So a little bit about the patient journey with Thrive. So really where this started was talking particularly about specialist care, being a specialist myself and seeing how long people often had to wait. You'd get referred to somebody, you'd wait 1.5 years to actually have your appointment. You'd show up and they would say, actually, you don't need to see me. 10 questions in, they say you actually needed to see someone else. And you start another 1.5 year long wait to see someone else. So what we did was we worked with a variety of different specialist groups and actually created intake questionnaires. And those questionnaires went to patients upon their referral. And so what it allowed to happen was appointments, when they happened much more efficiently and effectively. And it also allowed some of the specialist groups to be able to say, actually, we don't need to see this person. We know from their answers that they actually belong in another pathway, in another queue. And so that allowed both the visits that did happen to happen much more quickly, and for patients to be able to have clarity as well, and to have a sense of interaction right away. So once they got that referral, they're already interacting with the system and getting feedback. They have a roadmap that they can see of where they are on their journey, but also on the healthcare side, so the clinician and the system can actually see all of the patients in their queue, how they've filled out their questionnaires, and based on how and what has been programmed in, depending on the specialist and what care they're going for, can actually prioritize them. So it's not necessarily first come, first serve, that people are actually being seen quickly if they need to be and having issues dealt with. That, and a lot of that really carried around operative care, and then that led into care plans. So essentially we would guide people through both a pre-appointment, post-appointment, pre-surgery, and then post-surgery, making sure that they really had this helping hand, and that if they needed to be in touch with a physician, they could very easily, but at the same time keeping them out of emergency rooms and doctors' offices, when in fact what they were going through was very normal and they just needed a little bit of support. So that's sort of what we did. It's all designed to be very easy. Patients can ask a lot of questions about words they don't understand in a digital format. We have people ranging from as young as 10 or 11 up into their late 80s, and really have had no problem at all with people navigating this process. So as this was starting to really roll out, we were about 2 years into this. We were in multiple provinces and fairly extensively in a variety of areas in British Columbia, giving physicians clinical summaries. These clinical summaries also, the patient, again, always has access to this. So if you're traveling, you're in Mexico, you need to go to see a doctor for some reason, you can just pull this up on your phone and either send it as an email, print it out, or just show it to somebody. So you're always traveling with your medical records, and you don't have to make a lot of phone calls to try and remember what had happened. So again, here we are dealing with all of this, and along comes COVID. We were having a board meeting in about the 3rd week of January, and one of the conversations we said is, you know, this COVID thing seems to be real, and seems to be coming. At that point, you know, there was not confirmed human-to-human transmission. Having lived through SARS as a clinician, as well as through swine flu, it became pretty clear that whether this was going to become something that was very dangerous for people or not, there was going to be a lot of concern. So what we did was immediately modify sort of our patient communication and questioning to be able to say, people are going to have a lot of questions about COVID, and what we don't want is for people to be waiting for 811, waiting at walk-in clinics, waiting in emergency departments or their GP's office to answer questions that are going to be very common to everybody across the country. So we kind of built without having a customer. So we just built a COVID app that basically used all of our underpinning technology to be able to essentially ask the questions and give people information. The province of British Columbia sort of recognized really very, very early that this was going to be an issue. Because of our existing relationships with them, we showed them what we had already built, and they incredibly quickly incorporated it into their public health policy, to what the province was doing. And they were the first to have sort of a very specific app like this that included a self-assessment tool, BC-CDC recommendations, and told you what to do and where to go. And what's really important is how dynamic this was. As we've learned more about COVID, and particularly in those early days, recommendations and things were changing every day to 2 days. And so this was not a fixed platform, and it's never intended to be. So it was adapting. We would get changes from the CDC and from public health, and within a couple of hours, those changes would be incorporated in the public-facing app. So people could get push notifications. They would also be getting updated information. The Government of Canada, through Health Canada, saw the same thing, put their own brand on it with a bit of their spin from Health Canada, and all the provinces that you can see listed at the bottom essentially took this on as well. So we've now had far more than 10 million people across Canada using this app and using the self-assessment tool. And it's been really interesting in getting feedback from those users about just how much it's changed what they were going to do and how they felt. So it became a very powerful communication tool. So it's downloaded and loaded on people's devices for several months. Both the BC and the Canada app were the 1 and 2 apps in the Apple App Store for health, as people were downloading these and using these. And it allowed us to do push notifications, in-app critical alerts, and be able to remind people to be able to do both sort of self-check assessments, to be able to follow those symptoms, had they reported symptoms.
1 minute, David.
Thank you very much. No, not a problem. So key features, as you can see here, are just sort of all the things that you would expect us to do. This is the sort of flow that people go through. And what I want to do is to get a little bit into the data of what actually happens. So one of the things is we were able to track by all of the different symptoms and rating them. And what we found is that we were able to see, based on what people were reporting, in advance of people reporting to public health, in advance of people reporting to their doctor, you were able to see spikes in COVID that were actually coming and where they were coming. So the Cargill plant in Alberta, we could see the spike in that area outside of Calgary prior to there actually being an outbreak there. The other thing that was critically important was that because we were able to communicate and provide reassurance and be able to provide a very personalized digital interaction, so it was their information and then public health information being applied to them, you could see that we were actually steering people away from resources if those resources were not required for them, leaving them available for others. So, you can see these reductions here of 47 people who would have gone to their family doctor or walk-in clinic and instead realized that they did not need to do that based on the CDC recommendations in public health. We do a lot with research and advocacy, so obviously with all of this data, we have the ability to provide that to public health, to researchers, to academics and UBC and other institutions that we work with, sort of, if it's their data, for them to be able to really analyze it very, very clearly. I think that just cuts me in under my 10 minutes there. But thank you very much for that, and happy to answer any questions whenever is the appropriate question time.
Thank you very much, James. That was a super presentation. We're having questions and answers after the next presentation and then at the end. And Amanda's just reminding me to use the chat box to put your questions in, and if you can preference them with the word question, that would be helpful. Let me now introduce our next speaker, Dr. Mariam Fedege. She completed her PhD in computing science at Simon Fraser University, and as a CIHR scholar at the Skin Research Training Center, she worked on the visualization and analysis of malignant features of skin lesions. In 2012, she co-founded Meta Optima Technology, where MoleScope, which is a mobile dermoscope, and Derm Engine, an intelligent dermatological platform, were developed for intelligent skin analytics, imaging, and management. In 2014, she won the Venture Prize from Coast Capital Savings. In 2016, Dr. Fedege made the Business in Vancouver's 40 Under 40 Awards for her innovative work and successful commercialization of Derm Engine and MoleScope. Recently, she was credited as one of BC's most influential women in BC Business Magazine, and her company was listed as a ready-to-rocket business in the area of digital health. And I'm delighted to be able to welcome Mariam again. Mariam, over to you.
Thanks. Thanks for the introduction. Can you hear me well? And I can share my screen. Okay, can you see my screen?
Yep.
Awesome, great. Thank you so much for having me. It's a great pleasure to join you today. Fantastic topic and conversation actually from, let me minimize this as well. From the previous talk, James, I've used the service. Thank you so much for developing it. You were taking it and it was required if we were going for any events, trips, or trainings that part of BCMC club for mountaineering. So we use the services. Thank you so much for developing it. And I think I'm one of those patients that you had, not patients, but Canadians who benefited from that. I want to say thanks for the amazing work you put together so quickly. So for today, I'm talking about from discovery to commercializing AI in real-life clinical settings. I actually decided to touch a little bit on the discovery side from my training and my PhD in computing science, and also show a couple of things, learnings really, lessons we've learned, best practices in commercializing AI, and what I think is important from the knowledge that we have so far. So I'm the CEO and co-founder of Meta Optima. This full disclosure I have now. I'm talking in scientific conferences. Sometimes there's a CME credit, so I didn't know about this specific event. I decided to have it as my second slide. The disclosure that I have, I am very proud to present a passionate team behind what we do, and Meta Optima, today we are proudly serving over 1.2 million patients globally. We've had over 4.7 million cases and serving over 1,000 medical centers, centers of excellence around the world. With the vision, the passion the team has for saving lives and serving patients, and at the end, I think it's saving costs and time for our doctors and healthcare workers in the front line, really to serve our patients globally. So I have a couple of slides about my journey. Where I started, this was me back in Iran in my high school. Actually, this was pre-university program. We had a lot of really passion for doing really well and also doing good. I always say, I think many people want to do good, but it's also important that you do it well in a good vehicle. So this is the only thing I remember from those days. I didn't want to be an entrepreneur. I didn't necessarily even want to do, PhD and go to graduate school, but I want to really do something that will be good, good for people, good for universe, and also do it well and not just have the good intention. And this is me when I joined the medical imaging lab and computing science department at SFU. But I had really the opportunity to get training in dermatology because of my scholarship from CIHR. I always say we have amazing programs in Canada that they are the foundation of building real applications, bringing technology to real life settings, and CIHR was that component in addition to INSERC, MyTech, and other programs, really in my case. And Dr. Tim Lee from BC Cancer Agency, and I had two dermatologists, patient supervisors as well. It was a really good time. It provided the opportunity for me to grow not just as a scientist, as a PhD student, but also to present what I had built, to present the results. And in my background, there are many of these awards that we won internationally, nationally for our work in analyzing images in dermatology to help our doctors with diagnostics. So these are the conferences I was presenting the results, or you know, the activities that I had as part of. Yeah. Sorry, I couldn't hear. Okay, I will continue. Yeah, and also following that, this was recognized by the Minister of State. I won the Best Doctoral Thesis Award, the Dean's Medal, and it really showed me the recognition for the scientific work that we had from the medical community, from the healthcare systems, and the great potential, not from just a scientific perspective, but also from the medical perspective, as I won the gold medal for the work that we presented in the World Congress of Dermatology. The focus that I had was on skin cancer. So skin cancer, I was really shocked to learn that skin cancer was the most common cancer, and 2 in 3 Australians develop skin cancer in their lifetime. 1 in 5 Americans, 1 in 7 Canadians, and if you diagnose it early, the survival rate is very high, almost 100% these days. That goes down to 15% with late diagnosis, and also the cost. If you diagnose it early, simple excision, $200. If it's metastasized advanced melanoma, it is costing over $150,000 actually for treating advanced melanoma. So really important to think about commercializing research was this, which was one of the chapters in my thesis, looking at the commercial systems and looking at the market opportunity and how big is the problem. So we looked at the numbers, 39 benign biopsies to find 1 melanoma in primary care. A lot of waste that we have for unnecessary procedures, unnecessary biopsies, surgeries. And even for dermatologists, expert dermatologists, this is 2 to 1. So even here we have 50% really waste in the system. On the other side, we have limited access to specialists, so low accuracy, missing cancer, late diagnosis is also costing us, you know, our healthcare system, and it's also costing patients' lives. So this was the summary that I had. Yes, what we've done in the research side, very successful from scientific perspective, has a big potential for commercialization. So the solution was really to have a system that is digitized, it's efficient, and it's going to help with better decisions, so that can save lives and save costs for the system. So we designed our Derm platform, which is the cloud-based system, and also we have devices that can help with imaging. The system works with other devices in the market as well. So you really make a lot of these small but sometimes difficult decisions how to design your platform to be able to guarantee the success, the adoption, and that was one of the decisions we made to make it inclusive. So we integrated with every single vendor that you could name in the space, although they could see us as a competitor, but very soon they learned that no, we're not competing with them. We are also serving their, you know, their clients and their users. When you talk about AI and dermatology, the expectation is that, oh, you have an app that you will take a photo, it will tell you this is cancer or not. That is a very, very simple one safe feature of Derm Engine. Derm Engine has over 44 algorithms. It's the full platform that is basically connecting with other systems that you have in the hospital, with your EMR system, with your pathology lab, and all of that. I'm going to show you here how it works. So if I have the image taken with my smartphone or digital camera in the clinic, I can add dermoscopy images. And also, this is our new diagnostic module that now we are actually working on the FDA submission to have a diagnostic feature in Derm Engine. What it does, it basically analyzes this image and it shows you the diagnosis that Derm Engine has for this case is basal cell carcinoma, and here's the distribution of probability for different cases, which is basically saying that it's not just a black box that's a 70% risk. It is really analyzing and showing you what this could be and what are the reasons. Which brings me to the important factor of explainable AI. I think one of the challenges in AI adoption in healthcare is that doctors necessarily don't understand if you put a number in front of them as a risk factor, why this is 70%, how the system calculated this, how I can trust this system. So we focus on bringing this feature early on to the system, that we have visual search. For the image, it's not just saying this is basal cell carcinoma, it's also showing you similar cases with the diagnosis, with the differentials, and this was, I believe, one of the key features that helped with our adoption, that today we can serve over 1.2 million patients because their doctors were actually seeing the value, they could understand the system, and they use the platform to serve their patients. So about a little bit about the algorithms. Of course, if you want to commercialize your system, you need clinical validation, and this should be compared against other systems and also against human experts. So we won the ISIC challenge, which was an international competition against other algorithms. We had top 3 positions. It was a really good, solid position in that competition. And also, our system was compared with over 511 human experts. And we also outperformed in that setting, which was published in Lancet Oncology in June 2019. And it's really interesting here. You can see the blue dots, which is coming from the human experts' precision in this ROC curve, accuracy, specificity versus sensitivity. This is their average. And here is the red chart, actually graph here, their mentioned ROC curve. So you can see how it outperforms the average physicians basically by a big difference, which is just simply showing the potential for the AI system that can learn from millions of cases, millions of patients, from thousands of, hundreds of thousands of doctors to serve you as your assistant in front of basically your patient. This is another study. Unfortunately, we didn't have time. There are really good publications recently in this domain that is showing that, okay, we have compared AI against human experts. We know it is working in the specific study setup, how we should implement it. This work is really interesting. It shows that it's actually by Google Health Team published in Nature in 2020. It is showing that if physicians are confident 5 out of 5, they are better than the AI system, the deep learning system that they had. But if they are not confident 5 out of 5, which means even for 4 and lower numbers, AI was performing better. Now it's getting more clear in what scenarios we should go to AI, and also like looking at differentials versus looking at the top diagnoses and comparing the accuracy in those different settings, which is also our focus now in real life implementations that we have. Just before this call, I was actually on the call with the executives for one of the biggest IHS systems in the US, serving millions of patients, how the system should be implemented to serve those settings. Another important matter, again, we don't have time to go to the specifics, but...
1 minute, Mariam.
Yes. How many minutes I have?
1.
1, okay. So yeah, this is about the bias and how we handle bias in implementing AI in healthcare. So the user bias, if your data is coming from a specialist center, so you will be biased towards the specialist settings, it will fail in the primary care setting. The patient bias, skin color is important, gender different, metadata. Data also, the sensors that you have for acquiring data is also important. So how you really address these edge cases and also the regulatory challenges. For a system that has the power of learning every day, you have to freeze it, and you have to go for approvals. Is it the right decision to do? So those are some of the implementation challenges that there are actually out there in healthcare, and we are trying to address those, and so far have been successful in proper implementation of AI. Thank you so much.
Thank you very much, Mariam. That was fantastic. So just a reminder to the audience, please use the chat box to put in questions. We have one question already from David, which is for James, and the question is, with regards to spikes and trends you observe in the specific geographies, perhaps, and in particular with types of searches for particular diseases, is this information transferred to the health authorities?
Great. Well, David, thank you very much for the question. So in terms of what you were seeing with spikes with COVID-related symptoms, for example, so in each province, the flow of information is slightly different. So, but most of the time it's going to the Center for Disease Control, and then they would then look at that data and then pass it down through as appropriate through to their health authorities. With Health Canada, the flow is a little bit different. They're looking at it for a slightly different reason. And Health Canada will also share their data. So, for example, some people will download the Canada app, but not a provincial one. And so it will then basically flow that information. They will share it with the provinces. In terms of the rest of our platform, when we're dealing with other diseases, essentially, yes, all of that data is shared with the people who've helped us design whatever the issue is, whether it's a pre-surgical one. And so it's really about creating that loop of information that keeps everybody really up to date and informed.
Excellent. I have another question for you. Since this is about discovery to commercialization, in your opening comments, David, you said that you, your brother, and somebody else sat down and thought of this idea, and then bingo, we've got Thrive Health. There were a few things that happened in the middle. Do you want to talk a little bit about that?
For sure. I mean, the interesting thing is that, you know, it was so interesting having two people with such, you know, deep history in technology and successfully building and transacting on technology companies and understanding data and what you could do. And on the flip side, me, who really had no understanding at all of technology and was a real neophyte, but understanding a lot more about the healthcare system from both the patient's perspective. I spent a fair amount of time both as a patient in the system as well as a provider in the system. And so it was really testing ideas. And each idea that we really went through was spending time saying, is this going to make a patient's life better? Is this going to fit with the paradigm of treatment that clinicians operate under and that the system operates under? And so it took us, you know, probably a year of trial and error and experimenting and working with different groups who were willing to work with us to test some of our theories, some of which were right and some of which were wrong, to get to the place where we really started to gain traction. And of course, one of the key things when you're entrepreneurial and you're doing these things is you're going to be constantly learning. And so every day is an evolution of what is working today and what is not working, and being very honest with yourself about where you're getting it right and where you're getting it wrong. Just staying focused on your goal, which in our case is providing great care and helping provide great care to patients and helping the system. So.
Excellent, thank you. Question for Mariam this time. What are your thoughts on using this technology you have for personal use versus through GPs?
It's a great question because we started with having patients in the center of our solution. We had the first digital dermoscope for patient use globally, and this was even 2015. We decided to focus on the provider network, offering the solution for their providers and even specialists in cancer centers because of the credibility that you need to have in the healthcare system for real-life implementations, and also having the support network for the patients. For example, we have now our Molescope Lite devices, which is for patients, and this is very affordable, 3 times more affordable than what we had before. And we are now pre-approved as part of ISC, Innovation Solutions Canada, for COVID-19 projects to serve high-risk cancer patients. So our solution will be available for high-risk cancer patients to be served from home. But it's not really just a matter of saying, here's the app, you know you have melanoma, sorry, there is no doctor to see you, right? It's all about saying that, hi, I'm your doctor, I have received your cases, it seems I need to see you soon. So that's basically the main implementation point that we had, having the network to support patients when the technology is accessible for patients. So we are already at patients' home. We sold and actually shipped last week thousands of units of our Molescope Lite to Australia because it's much more advanced there. Patients have access to these devices. It's specifically with telemedicine now. The appointments were canceled. These patients need to be seen and monitored regularly. So they are using the platform. However, it's not just that AI piece. So we don't turn it on for patients at this point. In the future, I'm sure it will be available for consumers.
Excellent. We have another question from Lynn Hossaimi, which is around Derm Engine. In terms of the clinical analytics and accuracy, what percentage of the data indicates retakes and or false positives?
There are different algorithms. As I mentioned, we have over 44 algorithms in the platform. So the false positives, for example, one of the classifiers that we have, and that is used for each triage, which means if you have 1,000 cases referred, you have limited access to specialists who should see who and basically how fast, how urgent are these cases. So we have sensitivity of about like 97, 98%, which is, of course, you can tune it based on the requirements for the system, with the specificity of over 87%, which is really, really good. However, this needs to be tuned for each setting. This needs to be validated in the patient population that you have, because this is, for example, for a major system that has the highest traffic of melanoma patients globally. Of course, this is for the highest patient setting. How this is going to work? In BC, we have the supercluster project that now we are working with Providence and looking at those numbers and validating how this is going to help with our referrals for our patients in BC from primary care to the specialist setting.
Excellent. One other question then, since you brought it up, for those people who aren't as clear about AI, can you talk a little bit about why you need 44 different algorithms?
Yes. When we talk about AI, it's about like what you think usually is it's enough that you have an image, it will give you diagnoses. But we don't realize how difficult is the workflow process for our doctors, how under digitized they are. Our doctors even are not imaging because they don't have time, which really goes back to like the first steps of visiting patients, having access to a specialist. So we have algorithms for referrals. You have 1,000 cases a day for one doctor, they can only see 20. Who should be seen first? This is adding to the backlog. So we have an algorithm for that. There is an algorithm that basically keeps track of cases for high-risk patients over time and can find changed lesions or the ones who need your attention. It's not about diagnosis. It's all about summarizing the visit that you have a patient with 200 spots compared with the previous visit. Good luck with comparing them one by one, right? So there are really needs for tools that can make dermatology a little bit more digital, a little bit more efficient, so our doctors can take that time to treat the patient. Unfortunately, a lot of their time is actually wasted in documentation, in admin part. It's really overhead heavy in terms of visits. So those 44 algorithms are used for workflow efficiency and also clinical decision support. I also showed you one of them, the most popular one, which is in the commercial system we have now, visual search. You have a case, it can compare with 4 million cases, and it can show you a selection of similar cases. And one of the doctors told me, oh, it's like my intelligent library. Uses pattern matching, shows you why the system said this is basal cell carcinoma. Like, doctor, look at similar cases. It's amazing sometimes how similar these cases are. So that's a decision support component. Yeah, I think we need more algorithms, and the new one will be in a drone. That is our new innovation. The first medical drone patent, we actually filed a patent that can examine now your patient. It takes under 2 minutes, full examination, 3D model built for the patient, boom. It's standardized, it's repeatable. That one alone will have over 40 algorithms, I'm sure.
Excellent. Well, fantastic. Well, thanks very much, Mariam. What we're going to do is we're going on to the next two presenters, and then we'll come back for questions at the end. So the next two presenters are Dr. J.J. Sidhu and Dr. Rich Lester, and let me introduce them. Dr. Sidhu is the department head for Vancouver Acute and Community Mental Health and Substance Abuse. He is the medical director for Vancouver Acute, Tertiary and Urgent Services, as well as the co-chair for the Provincial Advisory Committee in the Mental Health Act. In addition to his administrative roles, Dr. Sidhu works as a consultant liaison psychiatrist at VGH and UBC Hospital. Dr. Rich Lester is a clinician researcher at UBC and VCH and co-founder of the WellTel International M Health Society and WellTel Inc., a social enterprise that delivers evidence-based digital patient-centered care around the world. WellTel is the recipient of multiple research awards, including the Grand Challenges Canada $1 Million Award for transitioning the M-Health service to scale in remote Kenya. His work has contributed to international guidelines on digital patient care. And I'm delighted to welcome JJ and Rich. Over to you.
Great, thank you. And I'm going to let Rich drive the PowerPoint. So Rich, you can share your slide deck there.
Yes, I will. Okay.
So I'm starting off. So I think the easy part because I'm just teeing up the challenge that was in front of us, and Dr. Lester and team, the partnership that we've developed, he's going to get into detail in terms of the solution side or the proposed solution to these challenges in mental health. And first of all, I'm just so impressed with the two previous presenters and the initiatives and work that they've done. It's quite inspiring. So my field is mental health, and what I'm going to talk about is some of the challenges that are in front of us. So as a medical director here, there's of a very large system, in fact, one of the largest systems in Canada where we're managing mental health issues, is just the high volume. And that's no different from cardiology or dermatology. But how do you manage volume where there are many doors to the system, including the emergency room, but we have multiple outpatient clinics and high risk. So the stakes are quite high. And then when I heard about Rich's program through WellTel, there was something quite attractive about it because, and he'll speak into it, that this is something that their technology or WellTel technology addressed, and something that was already taking shape in other parts of the system, a project that they had done with medicine. So that was sort of the inceptions of that partnership. One of our clinics alone, 140 contacts per day on average. That's our access and assessment center. And what that service does, it allows for transitions from an inpatient setting to an outpatient setting where we can transition very, very sick individuals, people who are struggling with issues like suicide or even homicidal ideation, psychosis, and that do need help through navigating the system. I should say that in mental health, like we know in other areas of healthcare, points of transition, they're a big deal and they can be quite risky. And that can be anything from switching from certainly from an inpatient to an outpatient setting, but even from one unit to another or one nursing shift to another. So where any point there is a handover of communication, we know that that's a area of concern and certainly no different in mental health. Something that we focus on in mental health and in psychiatry for sure is that continuity of relationship with the patient. Something that it's certainly something we do in other areas, but we really focus on this concept of therapeutic alliance with a patient who's, for example, been admitted to an inpatient unit for suicidal ideation, and they've worked with a team. And now we're handing them over to another team. And there might be a gap in terms of that connection. It could be a different individual. It certainly will be a different individual, an individual who they'll be meeting and sharing their story with. There can be elements of anxiety about meeting that new team. And that's something that that we've looked at ways of addressing, and sometimes just given the volume of patients, those connections are not as timely as we would hope them to be. So sometimes there are gaps. And then this last point of a new metric. So in healthcare, we know we have things like lengths of stay, we have complication rates, we have admission rates, and we do apply those to our mental health population, but it feels like there's something missing. So those are process measures that from a very high level kind of indicate how people are flowing through the system, but with respect to a qualitative measure, that's been, I think, something, there's a gap in terms of knowing the being able to quantify sort of the work or describe qualitatively the work that we're doing and if we're doing a good job. So with that, those are some of the high level kind of issues that I struggled with, and maybe right now I'm going to pass it over to Rich for his description of WellTel.
Okay, thanks everyone. And first I'll just do a check. Can you see the screen changing? Because I have my PowerPoint's taken over my Zoom view. Is that okay? Yeah. Okay, thanks. So thanks, JJ. It's really great working with clinical leaders, of course, that are interested in addressing problems. And mental health is really one of these cross-cutting things that it's always been part of what we do, but never a focus in what we do. So we're really excited about this project, which we'll highlight today. But really, this is even a cancer care example of the complex system that a patient has to navigate, between hospitals, points of care, families, houses, labs, and so on. And really, there's a lot of barriers potential to that community continuity of care. But there's two things that remain unchanged: the patient themselves and their mobile phone tends to follow them. So it's really an opportunity for this to be a point of contact through their continuity of care and support. And it also means that this is consolidated in one place. So for the care provider, it's much easier to provide that continuity. And as we'll see, perhaps do some quality improvement based on the data that's collected. So just going back, WellTel actually had its beginning during the HIV pandemic. So I'm an infectious disease physician at Vancouver General Hospital, but I started my postdoc doing HIV research in Kenya, where people were really worried about adherence. And we had saw the opportunity, and it was actually the first we know of globally of using cell phones to reach out directly to patients to support patient care. And we ended up doing a randomized trial of our interactive open language text message check-in, which improved HIV outcomes and treatment. And we published that early on in the Lancet. There were some articles in Scientific America and so on. There's a link there if you want to see. But over time, that's progressed to, we moved back to Canada, and we saw the same challenges actually here. I grew up in a smaller northern town. But even in Vancouver, and you can be isolated within your urban areas. So we've really extended our research program. And I know that the theme of this is discovery to research. So we really did a lot of background research, qualitative research, up to validation and randomized trials and implementation research over time, and publishing that, which I think helps to also drive the change. Sometimes you can feel as an innovation, you're too far ahead of the curve in terms of adoption in health authorities. But getting the word out and publishing can help. And I went back looking at slides to 2012, and Dr. Melanie Murray used this from the Oak Tree Clinic in Vancouver, barriers to adherence, when they were using WellTel as a program. And these come up to very much of the same issues that we're working with Dr. Sidhu and his group today, which is really about, sometimes substance abuse, mental health, and these all affect adherence and outcomes, and how do we support those? So WellTel was really, we did form, in fact, for moving evidence to research and discovery to research, we ended up forming first a nonprofit and then a company, so we can work within the Canadian and other ecosystems to develop this as a tool that can be scaled for mental health, chronic diseases, and other. And now it's available, but it still follows on that fundamental basis of text messaging to patients at its base. And that's because, and I'll show you, even today in Vancouver, we'll show you results of the study, it's about reach and equity, reaching those that have the easiest access. And text messaging is by far still one of the leading reasons. We're working in a number of areas there. So why SMS? 24 billion sent. There's 7.7 billion people in the world, 24 billion text messages sent and received each day. It's by far past every other form of digital communication. And it's the most accessible, and patients are expecting it of their healthcare providers. This was a study from the US where it's increasing, but it really is about access. Teenagers may not answer the phone, they'll only text, and also, but at every age, it's really become something. But it's a part of the communication that we do, so it's about reaching people. And without spending too much time, an example, again, when I went back to, we're just getting our project started with mental health at VGH, but I went back and I saw this slide too, which was a simple text message based on the well tell, ask, don't tell, how are you? And a patient responded really good. A friend of ours was murdered last Thursday. She was only 23. And the HIV nurse then at Oak Tree said, I'm sorry to hear that, and was able to provide the support and link that person to the right care in a timely way. And again, it's about the relationship, the continuity of care, and also directing people. And it's through a very simple and accessible process. And in fact, they did it's the science behind it, did a validation study among vulnerable populations in Vancouver and felt similar to Kenya that this very simple approach improved HIV treatment outcomes in Vancouver. So the solution is about connecting patients to care. Now, of course, technology needs to advance with the time. We're very much in favor of using the mode of technology that accesses people, not just in the future, but today, and leaves the fewest people behind. So it's based on text messaging, but you can easily integrate and go to phone calls, to video, and write notes and share photos. I'm an infectious disease physician. I can see someone's wound, pictures of it as they move forward. And I think in mental health, that continuity is really, again, it's cross-cutting, as you saw, even when that wasn't the focus. So I think we're really going to be able to help establish that post-discharge continuity of care. I'll move quickly, and it's just only time for overviews, but what can we learn from the data from this? So we have lots of evidence and grounded into how to support patients for better outcomes, hopefully reduce readmissions in this case, but can we learn from that data? And this is something it used to take, you know, a PhD student would go through 10,000 conversations and categorize them manually. But now we have tools, and we're partnered with the data science team at UBC in visualizing automatically, where you can interactively look at, de-identify and look at this data and say, what are my patients talking about? What are their priorities? And what are they talking about with their healthcare provider? And we can even look at things like sentiment analysis. If you change an intervention, is the discussion around that become more positive or negative? And also with Dr. Sidhu and others, we're going to be looking, of course, in mental health, and are there indicators of, you know, depression, both at a population level or at individual level. There's other research which I'll show, you know, just to get kind of, a lot of it's being applied to social media. So for instance, this was, I think, of Twitter evaluations during COVID, a population study done that showed that the conversations of people and their emotions in the general population have changed during COVID times. But when we're applying this, as we are, to our own patient population, we can actually be much more specific and say, what are our patients talking about? What are their priorities? And maybe even pick up some flags in change of mental health status. So we're really quite excited about that. And I'll come right back to it's about access and equity. Dr. Murray, who I referred to earlier, said something, you know, it's 10% of your patients that take up 90% of your time. And they also influence mostly the health outcomes. It's those 10% with the greatest challenges. And we did a survey at Vancouver General Hospital for the medical wards, acute medical wards, in January, just as COVID was, just before it became recognized here. And 30% of older patients, of course, because they're the medical ones, but they're the same ones that are most likely to die if they get COVID. And 30% of them did not have access to a smartphone, wouldn't be able to use an app, and if you were to actually add passwords in that, it could even be less.
1 minute, Rich.
1 minute? Okay, so this is, I think, my last slide, or second last slide, thank you. And really, so it's about the discovery to commercialization, I think, as was said in the intro, isn't just about profit and so on. It's about making your innovations accessible. And so we've been working in asthma, H2 Home, various health authorities, some First Nations projects, a lot of research partners in the US, Africa, UK, and then we got a first round of COVID funding from the federal government this year. And then changing that to operationalized status and licensing and so on, with the idea, of course, that we really need to bring this as a service. And I know, and it's actually events like this that help hopefully try to bridge those gaps between discovery research that academia into products and services available in the real world. And the key point of many that you can make in that process, of course, is partnerships. And we've heard that from our other great speakers. Really, to get it right, you need to know, it takes a number of partnerships. And I think the opportunity to partner between academic and health authorities and patients and clinical providers is key. And I will leave it at that. Thank you.
Thank you very much. It turns out we're still waiting for Kendall. So maybe I can ask you a question while he gets out of his other meeting and gets into this one. This is from David. This is such an important area of research and technology that has been brought to the forefront in recent times. Do you see this having a role in addressing loneliness, depression in seniors at home, long-term care settings?
JJ, would you like to answer that one, or?
Yeah, I think there is certainly potential, and from my perspective, from a medical lead perspective, is first I want to know, can we do this in this population? And if we can do this in this very ill population in an acute setting or tertiary setting with folks transitioning to community, then that would be a natural next step. Where I'm looking at the utility of WellTel is certainly identifying high risk. For example, out of 140 calls I had mentioned, many of those are people calling about suicidal ideation. However, not everyone is at imminent risk for suicidal ideation, so it's being able to stratify that risk, red, yellow, green, where we're able to kind of send out people or individuals. Then once you kind of, in my mind, have a handle of that level, then you're also looking at those other stratifications, and then pairing that up with other interventions, whether in terms of a geriatric psychiatry population or in care homes, you're able to alert the appropriate healthcare professionals that, listen, this is an issue or something that we need to key in on. So I could see it certainly being on that continuum.
And I'll maybe just add, even from day one of the most impactful things, when HIV was very stigmatized, sometimes people considered it a lifeline. We heard the same thing from our project in Haida Gwaii up on the island, that ability to reach out to that trusted person, your care provider, establishes that relationship, which I think is one of the key feedback, elements of feedback we've had so far.
Maybe I can ask another question then around that, is how do you get people into using the system and keeping them using it?
So adoption rates have been very high in the projects that we've had. So adoption is two-sided, patients and then healthcare providers. So getting healthcare providers to adopt is a lot of the things you've been hearing about today. They want to know, does it work? Is it going to cause me headaches, or is it going to save me headaches? And we spend a lot of time on both of those aspects. So the patient side has always been extremely positive. They say it feels like someone cares. I just, feedback today, it comes in and it's just like, this is so much a better way to be in touch with my healthcare providers. It's almost what they would expect in modern times. Adopting by the healthcare providers, there's more of a technology adoption challenge, and then there's also the system, the health authority sides to navigate. People have mentioned that some of the challenges here. So it's one of the things we're really looking at, and our decision support team is looking at adoption. Yeah.
Super, thank you. So I'll come back to, there's another question for you, but we'll come back at the end because Kendall has joined us. So let me introduce Dr. Kendall Ho. He's a practicing emergency medicine specialist, professor, and lead of the Digital Emergency Medicine Unit in UBC Department of Emergency Medicine. He's also the lead of real-time virtual support of the BC Emergency Medicine Network. Dr. Ho is the inaugural academic director of the UBC Community Health and Wellbeing Cloud Innovation Center. He is the executive director of the Intercultural Online Health Network, ICON, a program funded by BC Ministry of Health Patients as Partners Initiative. to support the indigenous and multicultural population for optimal management of chronic diseases through in-person and digital approaches. He's a member of the BC Ministry of Health Digital Health Provincial Clinical Leadership Committee, BC Academic Health Sciences Council, Clinical Trials Advisory Committee, the National Research Council Medical Devices Research Centre Advisory Council, and Health Canada Scientific Advisory Committee on Digital Health Technologies. And with that, I'm going to hand it over to Kendall.
Thank you so much, Ian. That's such a kind introduction. Ladies and gentlemen, it's my honor to be here. David, thank you so much for inviting me to participate in this series of discussion about from discovery to commercialization. I wonder if I may start sharing my screen. I hope I won't override something. I will go there, and if someone can give me a thumbs up so that I can make sure. Thank you. All right. Really appreciate it. As Ian said, I'm an emergency doctor and very fortunate to be in the area of research and some innovation and technology. And so what I'd like to do in the next 10 minutes just to share some of my own lessons along the journey. Now, I bleed a lot. You can see in my forehead lots of scars. And I hope that some of these lessons might be helpful. And really, it's a bit of a stimulus for us to have some dialogue, conversation, knowledge exchange today. I grew up in Hong Kong. And so when I grew up in Hong Kong, one of my favorite shows when I grew up was Lassie. And I really like watching TV. My parents didn't want me to, but this is the program I always go to. And the reason I want to raise this is this, that, you know, of course, I love to learn about dogs and how faithful they are and how smart they are. And that journey, not only in each episode, give me a bit of nugget of the story, but as we go through the series, I get to learn more and more about dogs. And so in the last few years, we actually started having a dog in our house. So this is my journey on life itself. But in many ways, I'm very fortunate to be involved in clinical care and also in research. Every single opportunity of research projects or discovery is in some ways an episode in the life of the journey of discovery. And I think as we go through the series, that I learn a lot of different kinds of things, but I try to stitch together maybe 4 lessons here that I'd like to share and see if you resonate with them. I think it really starts with this. I think be it discovery for commercialization, be it research, be it clinical curiosity, it starts with the question why. Because if there's a clinical gap, why is there a clinical gap? How do we want to solve it? If there's a technological gap, why do we want to discover something to address that particular gap? I get to know Richard's really excellent the text messaging solution. It was a huge, huge solution, very effective solution to fill a very important gap. And so I think starting with why and asking that question is going to be very important. Einstein said, if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem, asking why in many ways, and 5 minutes coming up with a solution. And in fact, by focusing on the question itself and thinking about asking why, it actually takes us to a very strong journey downstream. And I'll come back to this why along the way. So in the same way like Lassie, I think the question is, why do you like the particular series? You know, there are a lot of Netflix series right now, a lot of TV, movies, you have Avengers. You know, is it the individual movies? Is it the story arc? Or is it at the end that Avengers were able to overcome the enemy? What is it? To me, I think it's both. At some point, it's about the journey that's invigorating. But at some point, it's to get to the destination so that I feel I have arrived. I can rest, I can look back, but I can also look forward. And so I think in the area of technology, in many ways, many of you are familiar with this diagram, the technology readiness level, or TRL. Innovation Canada certainly uses the scale from TRL 1, which primarily is like an idea, a vaporware. You haven't really put anything into it, but it's a great idea, to TRL 3, which is you have now put together a proof of concept, something that becomes tangible, something that people can see, not just to imagine your solution, but start to see what your solution look like. Through TRL 6, which is once you've gone through some usability testing, then you can actually have a solution that may be ready to start clinical trials and testing. And through TRL 8, where you have a randomized controlled trial, you start to not only in one hospital, maybe a few hospitals, to TRL 9, where there's a global adoption or a Canadian adoption, depending on what your discovery commercialization is about. This is a journey from TRL 1 to 9, and these steps are not even. There'll be times it's easy, but it's famous that there are two valleys of death. And in fact, the first valley of death is from development to commercialization. This is the point where you may have a technology expert developing the tool. You may have a clinician working together. But to convince other clinicians, to convince a health system to partially adopt your solution, to test it, to do some experiment with it, to do usability testing of it, that is the challenge from TRL 3 to TRL 7. Typically, that's a valley of death. And the second valley of death is once you get to a solution, you really not now wanting to market it. You want health authorities, hospitals, health systems, communities, patients, community members to adopt it. And that's the second commercialization of rollout, where how do you focus? It's a different kind of focus of what you need to do. And you need to engage. It's about, in science, we talk about knowledge translation or implementation science. In health system, it's called scale up and spread. And commercialization is about, making it mainstream. And also, how do you plan and do resourcing to do that? And so typically, these two valleys feels sometimes like quicksand, and we suck us in. And when we get to these, I think that's when the original vision becomes very important. To come back to not what we are doing, not how we're doing it, but why did we do it in the first place? Why are we going through this journey? Why am I hitting my head against the door? What was the reason for that? I think the lesson is about this. What's my place in this journey from discovery commercialization? Am I a clinician? Am I a researcher? And am I an entrepreneur? Am I all three of them? I was considering putting this slide before the TRLs slide. But I put it here for this reason. Because for me, truly, I thought when I first started with the vision, I could do all three. But I rapidly realized, especially when I get into TRLs, that there's no way I can take all three positions. To be an excellent clinician, I need to read a lot, I need to treat a lot, I need to do a lot of clinical practice to get good at it. To be an excellent researcher, I need to learn how to do the research questions, understand different methodologies, apply it in the right context, the right time to find the right evidence. To be an entrepreneur, I need to understand how to take commercialization to scale. In fact, it was very interesting a conversation with an entrepreneur friend of mine in Toronto. We had a chance to do a trip in Paris, so I had a half a day to speak with him. And he taught me a lot, and I like him a lot. I respect him a lot, great businessman. But one thing he said triggered me was he said, at the end of the day, I'm very fortunate, I'm very successful in my business, I make a lot of money. But right now, it's not about making money. It's about how do we get an opportunity to make more money. Now, it may sound a little bit too commercial or business-like, but in some ways, I go through that myself as a researcher. Of course, I always need more grant funding, no question about that. But sometimes it's about the fact that I just want another grant. Not necessarily because I need the money, but I just want another grant. It may sound too self-serving, but that drive to want to make sure that you go to excellence, and that drive as an entrepreneur, or that drive to become a clinician, I want to diagnose this problem even better. I don't just want the bottom line. I want to get better on it. I think we can be good at one, for sure. We may be able to get at two, but to expect myself to do all three will be challenging. Yet, all three of them are necessary. Innovation rests at the center of that, or health innovation rests at the center.
Kendall, you've got 1 minute left.
Oh, you bet. Okay, sounds good.
Okay,
and so my next slide, and really is my second and final slide, is that you really need the right partners. And so I think I need to figure out what I am. Am I a researcher? Am I a clinician? Am I an entrepreneur? and then find the right partners to complement that triangulation of all those people to be successful. And the final slide says that I think it's about affirming resolution. I use the word affirming in two ways. Not only is it an affirming resolution for me to move forward, but I need my journey to affirm myself to continue, because failures will come. Those valleys of death can drag us down, but success is going from failure to failure without loss of enthusiasm. So I hope that these lessons are helpful. It certainly helped me to get through those tough times, helped me to have the guts to jump the gap, to get to the other side. I hope that this is also helpful to you. Thank you very much for your attention.
Thank you very much, Kendall. And before you kind of disappear, I've got two quite specific questions, and we'll go to some more general ones for everybody to answer. David asks, what could health authorities do to fill in or remove the valleys of death? What are the lessons learned in other jurisdictions that we could actually implement here in BC?
Yeah. Thank you for that. I think in general, policymakers and health administrators are really diligent in, one, maintaining the current health system to deliver type of services that they need to deliver. And second, they are primarily risk averse, not because they don't want to take risk, but I think from business point of view, I was talking to my brother-in-law, if you succeed 60% of the time and fail 40% of the time, you have a successful business. In health, you can succeed 99% of the time, and that 1% of the time with a Vancouver Sun story, with a Globe and Mail story, it destroys a health body's credibility. And so I think from that particular lens, I think building agency is very important. It's not like walking into the door with the CEO and say, adopt this is a great reason, here's evidence. But really it's about how do you translate the evidence into the system that gets integrated so that it can become an impactful piece that where the CEO wants to go, or the Ministry of Health or Health Authority wants to go. COVID was a transformative time, and it's an unusual time, that virtual care was 10% adoption, now jumped to about 60% adoption over a 6-month period. That's very unusual. But I think looking for those opportunities, building relationship with health authorities, looking for a right time to introduce innovation would be my suggestion.
Excellent, thank you. I've got a question from Lillian, actually, and that is, how do physicians get paid for the service? And I think this was directed to JJ and Rich, but it could equally apply to Mariam and James. So perhaps I'll leave it as an open question. So who wants to go first?
I'll do a quick comment because I think it came after, but I think it could apply to the others. So first of all, there's different pay and fee models, as you know, in healthcare. So in British Columbia, at least, we have a central pay model, the medical services plan, which you bill, and they have telehealth models. Actually, in COVID, they allowed almost everyone. So some of the models that are being used, there's an enterprise model where a health authority or an organization can license and adopt it on your behalf of the physician, and then you just make your money as a physician by doing your regular work as you would. You're just using the tools that allow you to do it, and hopefully more efficiently and effectively. The other is that the potential for building in, small components of that billing that comes off, and many of the models are like that. In COVID, that hasn't happened as much. The telehealth fee components have changed. That's an evolving program. I think it is something that needs to evolve in our health system as we adopt technologies. But essentially, with the tool, you get paid by doing the work that you do, and this is one of the tools that helps you to do that.
Okay. Mariam and James, you want to
make a comment? I can also answer in our case. So 99% of our clients, customers are outside of Canada. So we have seen different payment systems. For example, in the U.S., there is a fee code for total body photography and managing high-risk patients. So doctors who are using our system are paid for that service. And our system is, for example, $400 a month versus $200,000 investment that they would have to be able to provide that service using the competitor product. That is the U.S. model. There's also the tele consult, direct to patient, and also provider to provider. fee codes that physicians have now more accessible because of COVID-19. And I basically agree with Richard, like it's more in our case enterprise model and business to business enterprise. Our clients are using the system and the entire network of hundreds of physicians, and the entity is paying for the system and their doctors are using it, and of course this is saving costs for the system with implementing a more affordable and higher quality and more efficient systems, and the physicians are also happy because they save their time and they can see more patients.
Excellent. Thank you.
Yeah, I would just echo that same sentiment. I mean, we don't charge physicians for the use of the tool. It tends to, or patients, it tends to be enterprise, so people like health authorities or system providers in other places. And the savings themselves, when we look at, for example, pre-surgical screening, we cut down on the use of administrative staff by 75%. So very quickly, it pays for itself. We cut down on the amount of time a physician needs to spend organizing and doing all the admin work by about 60%. So in terms of, you know, the physician, their billing really isn't any different. They're just able to do a lot more with their time. And given most systems are fee for service, they do better and provide higher quality care. So,
excellent, thank you. I have another question actually. Two more questions. One again from Lillian is, what is your top tip to find the right partner? I've got a vested interest in asking this one, obviously.
I can answer quickly about our case. So this was, for our platform and our solution, it usually starts from centers of excellence, because the level of innovation it had, it wasn't like a typical dermatology office that is all we want to use this. It was the best melanoma center in the country. It was the best one basically globally that said, oh, we want to see how this could help us. So we had our champions, key opinion leaders, who were basically working harder than our team to get the contract done with the hospital. They were negotiating with their CIOs and CFOs. So for us, our key partnership started with the key opinion leader who was doing the top research. And basically, I always say these doctors are moving the borders of science in what they do. So these are the ones that say, okay, here's the solution. We're going to go with this. And they convince the hospital, the health authority that they need it for their patients.
Great. Anybody else?
Maybe I'll jump in. I'm thinking of three things that might be helpful. One is, I think, internally, if I am clear what kind of partner I need, it helps that partner to understand what he or she wants or not want to do, want to join me. So that clarity to start will be important. But secondly, I think it's about what's in it for that partner. I think, you know, it's a great vision, love it, but, you know, what's the payment model? What can I get out of it? What's the IP? What's the publications? And where's the market, etc. I think what's in it for them is going to be very important. But I think going past those two, I think the real test of a strong partnership is what can we co-create together? I think understanding the partnership, understanding what you bring to the table, they bring to the table, what each of you get, it's great. But at the end of the day, it's the co-creation that really galvanizes the relationship to one of transactional, to one of future partnership as you move forward.
Great, thank you.
I might comment just from our perspective. Prior to connecting with Rich and team, we did have discussions with other companies around our issues. And what really attracted us to the WellTel program was their experience in East Africa, where we could draw parallels to similar populations where many of our individuals may not have very fancy technology, but it was a demonstrated effective program over there. Additionally, just the relationship is an incredibly important thing. I mentioned it with our patients, but just being able to have these discussions and feel that they appreciate what you're trying to convey to them, and then receptive. They're not this absence of rigidity where they're able to adapt what this very this very detailed initiative that they've created, but are hearing where it can land with us and be useful. And third, I know where Rich's office is, so I can just show up and at his door. Right? If something's going wrong, he's going to hear about it.
Excellent. James, you want to add anything?
All I would add is just that I think that to us, the most important thing in any partner, whether they're a clinical partner, whether not with Thrive, but in my other ventures when I had investors, that philosophically you're aligned, you're traveling the same direction, because getting into bed with the wrong person in any one of those important dimensions in your company, it slows you down and creates headaches that there's enough headaches, as Kendall so easily pointed out, there's enough valleys of death. The last thing you need to not be aligned with a partner. So take the time and find the right partners.
Excellent. So in the interest of time, before I hand it back to David, I've got two quick fire questions for you all. First one is, and you've got like 10 seconds to answer. So how has the appetite for investment changed in recent years? James, since you're there.
I think in health tech, the appetite for investment is big. We have a lot of incoming interest for investment. We haven't needed it, but it's nice to know that it's there. So,
excellent. JJ, Rich?
Rich, I'll let you answer that. Oh, you're on mute.
Thank you, Tech. Tech tip, unmute. So COVID actually changed a lot of things, if you mean what's happening in the environment now. So one of the things we found is that people, because the economy was so uncertain, investment, we were hearing people that would normally invest are also a little bit more cautious with the times. But on the other hand, we're in a sector where suddenly digital health became front and center. It became almost like a rescue mechanism within this pandemic to try and do things new and in different ways. So I think it's we'll call it a hot time. It's a very challenging time for those mixed reasons, but certainly the interest is there for digital health, which is, I think there's going to be no time like this. It's people don't like war analogies often, and I don't blame them, but those are airplanes advanced in the world wars, and I think this is a time where digital health really can make a lot of progress.
Okay. Mariam?
I think we are in the intersection of AI and healthcare, which is a very hot topic, very interesting space for investments. The market was very hot actually before COVID-19. With COVID-19, we had a stroke, like everything was frozen. Investors were taking care of their portfolio companies, but again, it's now back, and I think I agree, COVID-19 could shine really light on the potential for digital health, for telemedicine, and we have a much richer pipeline in sales and also more investment interest from the investment community. So our pipeline is much bigger, for sure. But yeah, it was a difficult time when everything was frozen and so much uncertainty that you don't really also want to raise funds in that situation. So we also paused our financing activities.
Kendall, thank you.
All right, 10 seconds. Two things. One is, what can you do in COVID? And two is, after COVID get normalized, what's being left, and what can you do to do the pent-up commercialization opportunities there? So those two things might be worth thinking about.
Okay, excellent. So Amanda, do I have time for one more?
I think we'll pass off to David at this point and to wrap things up.
Yeah, I mean, it's been an outstanding session. I think it's so exciting to see all this technology being developed in our backyard and having an impact potentially around the world. I'd love to thank Ian for doing a great job moderating and all the speakers, and a huge thanks to Kara, Vivian, and Amanda at the top of your screens for all the work they did to organize this session. And going forward, we have another session, just to remind everyone, November 26th, that'll be on integrating medical devices to streamline healthcare, and we've got a great lineup of speakers. We're also looking for suggestions if you want to fill out the survey. We won't be doing a session in December, but we'll be back again in January, and we're thinking about doing one possibly around microbiome, but then we're open from there on as far as suggested speakers and topics. And so with that, I'd like to thank everyone for an outstanding session and have a great evening. Thank you.
Thank you, David. Thank you, Ian.
Bye-bye.
Thank you.
Thanks.
Your call will be disconnected.